Morning, everybody. So my topic today is evaluation of a 3D microscope display for surgical learning. So as we know, when we are doing phacoemulsification for novice surgeons, there is a steep learning curve involved. So for this study, we try to use a 3D microscope to see if surgeons would learn a little faster and safer. So achieving competence requires you to get fine motor skills, have good depth perception and spatial awareness. There have been attempts to use some techniques to shorten the learning curve. We use a 3D microscope. So how this works is, as we know, the 3D systems have two high definition cameras that capture two different angles of view. It's a processed by an image processor and transmitted to a high resolution screen. So what we did was, in this method, we had 20 surgeons, all of them who had very less experience with cataract surgery. All had performed less than 10 surgeries. Each patient was given 20 cataract surgeries to perform, and all of them were well dilated pupils and very standard grade of cataract. And all of the surgeons performed 10 surgeries on the 3D system and 10 on the regular traditional microscope system. And we all used a standard operating procedure. So every step of the surgery was very standardized. They all used the same instruments, same techniques, and same viscoelastic, same phacoemulsification machine, same parameters. So we knew that the procedure was fully standardized for all the surgeries. So this is the 3D system. We used the Zeiss RTO800, and there was always a supervising surgeon involved. Whenever there's a complication or when the surgeon had any difficulty, the surgery was taken over. And this is with the traditional microscope system. We use the Zeiss Lumira system, where the surgeon was operating through the traditional binoculars and the supervising surgeon is seeing through the side scope. We use the ICO grading for phacoemulsification, which is a very standardized grading to grade every step of the phaco surgery. There are a total of 20 steps in this rubric, and there's a grade of between 2 to 5 that you have to grade the novice surgeon with. So there was one attending surgeon and a third supervisor who was seeing all the steps of the surgery and were given the appropriate grade for every step. So the rubric is very, very specific. So in case the certain step of the surgery had to be taken over, for that step, the novice surgeon in question gets a score of 0. So we followed this. So we had a total of 400 cases. Post-operative parameters were seen at the end of 1 month. BCVA was seen for all patients at the end of 1 month. The parameters that were checked were all the ICU OSCAR steps. We used the Kolmogorov-Smirnov and Shapiro-Wilks test and Mann-Whitney-U for non-bad data. So we analyzed this. We also gave a questionnaire to all of the novice surgeons just to see what their subjective response was. This is the data. This is the cumulative score. As we see here, the minimum score you can get is 40. The maximum you can get is 100. Here is the difference in the bar and whisker plot between the 3D and the traditional microscope surgeries. As we see here, whenever they performed with the 3D microscope, the surgeons scored a lot better. This is the time taken. The surgeons, when they performed with the 3D microscope, took lesser time, whereas in the traditional microscope, they took more time. Overall, in terms of visual acuity, there was no difference. Complications-wise, there was no difference between the two, because the most common complication was PCR followed by DMD. But when comparison, when we are seeing the steps of the surgery, all the surgeons performed better on the 3D microscope, and individual steps such as capsule access completion, insertion of instruments into the eye, irrigation aspiration, and spatial awareness were all better on the 3D microscope. Here is the step-by-step breakdown. As we see here in the first 6 steps, capsular access completion was done much better on the 3D microscope. The other steps, when we start doing the phacoemulsification, like trenching, nucleus aspiration, rotation, all of this was done much better on the 3D system in comparison to the traditional microscope system. This is the final few steps, all of which again on the starred steps are the significantly better steps on the 3D system. This is the questionnaire response. All of the doctors unanimously responded that they felt very comfortable using the 3D system and felt no difficulty at all when transitioning from 3D to traditional microscope. So our inference is here that the 3D system gave a better quality of steps. The scores were higher, time taken was lesser, but in terms of visual acuity, there was no difference between the two. So in the discussion, we can say that the overall competence of the surgeons was better because they had better depth perception, better spatial awareness when using the 3D system. So this has already been used variously in vitreoretinal surgeries. So our study mirrored the findings in the previous papers where the 3D system was used for VR surgeries, where novice surgeons performed better. So I conclude to say the 3D heads-up system enhances stereopsis and ergonomics, makes it a valuable training tool for novice surgeons, and therefore can be used in the future as a standard of care when teaching novice surgeons phacoemulsification. Thank you for your attention.
Nice study. Which
Yes.
3D heads-up display did you use?
The Zeiss RTO.
RTO.
Yeah.
Okay.
So Narayana Nethrali is very rich. You can have these kind of arrangements.
So I'm not from Naranetra, guys.
I'm sorry. Okay. Anyway,
Okay.
so yeah, point number one.
Yes,
The
sir.
point is, it's a very very costly affair.
True.
It's not a one-time purchase, but it's
Yeah.
also you have to go for an annual maintenance contract and
Yeah.
CMC etc. So it's very very costly affair. And what I feel, I've used this for 3-4 months, and I didn't like it because if you do the surgery for a longer time, you get a headache because you have to have some kind of a difference of image in both the eyes to get the stereopsis.
Correct.
And number three is there is always a little bit of gap real time. You get the image after a fraction, a few more seconds. So that's the problem. So what is your take on this?
Okay, sir, as in terms of the lag time, I'm not sure which machine that you are using, but in the RTO, the lag is very imperceptible. Technically, there is a very minute lag, but practically when we use it, it is not there. In terms of the comfortability, ease of use, the funny thing is, experienced surgeons who have done 10,000s of surgeries, they find it more difficult to adapt to the system. Whereas in this study, we all use novice surgeons. We feel the neuroplasticity is better. So they're able to adapt faster to the 3D system in comparison to experienced surgeons who have been doing thousands of surgeries on the traditional microscope.
So this is not for the experienced surgeons.
It's not
Okay,
for
this
the old surgeons. It's for the
No.
Fantastic.
Yeah, right.
So there's a learning curve to it? I mean, after how many cases did you take this data of the surgeons?
So no, eventually everybody learns, ma'am. So it
What
depends.
is that
but
number?
Yeah, what is the learning curve?
it's
How many surgeons?
it's very variable, ma'am. So see, but as of now, all the surgeons at the center, experienced, novice, everyone is using the 3D
Have you
now.
used?
Sorry, ma'am.
Have you been using
Yeah.
this?
Yeah. So now all my surgeries
What do you
are
think
on
are
3D.
the disadvantages of?
Only disadvantage is the
Downsides,
turnover time because it's a fixed monitor and one bed. You can't have two beds, so you can't do right left. So you have to do all rights and then all left. So the turnover time in terms of bringing the patient in and all of that
For
is
a high volume
high volumes
center?
little more. Yeah.
Okay, I have seen surgeons having this RTO and finally operating through the oculars.
Yes.
What is the experience,
Thank you.
if you continuously doing the surgery on 3D?
Yeah.
Continuous surgeries, let's for 1 hour, 2 or 3 hours.
Ergonomics is much better, so you're not hunching over, you're not looking into the binoculars, so you feel more relaxed and comfortable as
Good
you're
for
operating.
neck and the
Exactly,
backache. What about
exactly.
the headache?
Exactly.
So you have some ache.
Yeah, I have some ache. Thank you very
Right.
much.
Thank you. Thank you, sir.